Good morning. It's Thursday, February 18th, and we're here for The Doc is In, Ask Dr. Arwady. I'm Sybil Madison, your Deputy Mayor for Education and Human Services. Very delighted to be here with Dr. Allison Arwady.
Good morning.
Your Commissioner for the Department of Public Health here in Chicago. This is where you can get the latest on COVID and vaccine in Chicago. We're glad that you're with us, and we want to answer your questions. You can send them by putting them in the box below, or you can send them via Facebook or Twitter using the hashtag AskDrArwady. All right, Doc, let's check our distance.
Looks
We're
good.
looking good. You want to just take it away?
I do. So let's take a quick look at our data. As a reminder, chicago.gov/coronavirus. That's your one-stop shop for everything related to COVID. There's tabs on there about vaccine. There's tabs about testing. There's lots of tabs about data. And within data, we'll start with our dashboard. So as always, we are looking at some good progress again here today. We're sitting still at a 3.6% positivity rate. That is literally the best we have seen since COVID started here in Chicago. We never
It's
got
unbelievable.
Yeah, it's
I
really
remember
good
a long
progress.
time ago, we were like, we'd like to get under 5.
Yeah.
And then we,
Wasn't that long ago.
well, it
Yes.
feels like it was
Yes.
a long time ago.
Yes.
So it's great to be at 3.6.
It is. And it really, some of this is about just improved testing access. We have good testing access here in Chicago. We've continued to roll out testing and having ongoing testing in higher risk settings and lower risk settings, but where we're doing surveillance. So really very pleased with that. We want to keep that in that low risk territory under 5%. But our case is also looking good. We're averaging 340 a day. That's under 400, which of course is the mark where we most want to be. We'd love to get that back down under 200, exactly. And if we're able to get that back down under 200, that would move us, really from the moderate more into that lower risk territory. But everything definitely heading the right direction, and I encourage people to explore more of the details. I'll also note on the positivity, the weekly positivity. The whole city is now in single digits as far as percent positivity, seeing improvements
That's
across
awesome.
the whole city. So really pleased with that. Also, just on vaccine, I'm not going to take the time because we spent a lot of time on Tuesday looking at data, but we did cross 2 important milestones. 1 in 10 Chicago residents has gotten at least that first dose, and 1 in 4 Chicago residents over 65 has gotten at least that first dose. As we shared out on Tuesday, our efficiency numbers have been very good. The storm has thrown a little wrench into this week, and I'm sure people will have questions about that, and we'll talk about it. But as of last week, setting aside the long-term care, 100% of our doses were in arms and reported 7 days after delivery, which is really, really good. Getting vaccine out just as quickly as it gets here. Some of the delay with the storm has been there, but we've done more than 450,000 vaccinations already here in Chicago,
Wow.
including both Chicago residents and non-Chicago residents. Nothing out of the ordinary or unexpected related to side effects, related to adverse events, anything like that. So things continue to really go very well. The main thing is just needing more vaccine.
Yeah, and that storm affected so many areas of the country, right? So
It did.
we're not alone in this boat of having that trouble.
It did. And I actually, I can see there's already questions coming, I know, that are about this. So maybe why don't we just start with the storm update? I know they're in there because we've been getting them.
Yes, well, here's one. With severe weather, should I be concerned about getting my vaccine later than the 3 or 4 weeks recommended time?
Okay, good. So just as a reminder for everybody, and we've kind of announced this and been sharing throughout the week, but the big winter storm that hit us here in Chicago did not only hit Chicago, of course. It really hit across the Midwest, even across the South, and there are parts of this country that are not as set up as we are here to handle large amounts of snow, ice, power loss, et cetera.
Yes.
And so most of our vaccine comes from the Midwest distribution centers, which happen to be for Moderna in Tennessee and for Pfizer broadly kind of coming through Kentucky. And so those vaccines come to us on trucks and they come to us
They're
over
not flown
roads. They're not generally flown in. It's interesting, you know, this is a big nationwide kind of distribution plan, and often what happens is vaccine will be flown to those different distribution centers for the different parts of the country, and then trucked from there is the traditional way that this is actually done. So vaccine does both fly and move on trucks, but in terms of that sort of how it actually gets to us, it comes on trucks from these Midwest distribution centers. And unfortunately, both of those areas just really, really hard hit. Tennessee in particular, you know, tornadoes on top of this, I mean, real problems. And so the Moderna vaccine was not able to ship out. It was not able to ship out Monday, Tuesday, Wednesday, and we're hoping they'll be able to ship out today. As of this morning, we had not gotten a further update on that. Obviously, there's been work to make all of this overnight delivery to get it going just as soon as it can be. But there are people, particularly on the Moderna side, meaning partners here in Chicago, that have not received vaccine, that they were anticipating getting early in this week. And so in that context, there have had to be a lot of doses rescheduled. And for the Pfizer vaccine, also some disruption there, but able to get that going a little bit faster from a storm perspective. So we did get most of the Pfizer that we were expecting in yesterday. I think we're hoping to get the rest of it in today. But it's been a really disruptive week for everybody. And I know then, to the person who's asking this question, that there has needed to be some rescheduling of appointments. Obviously, if we've been doing a good job of putting all the vaccine into arms, there isn't vaccine sort of sitting on shelves to be able to get appointments. So important for people to know, as far as those second doses, whether it's the Pfizer or the Moderna, the Pfizer dose is typically scheduled 3 weeks later, and the Moderna second dose is scheduled 4 weeks later. You can get it up to 4 days earlier than you would have been scheduled. So there are, in some cases, there are people moving things even earlier related to the storm. And in terms of getting it later, we of course want people to get it on time, partly because that's how we distribute vaccine, and we really expect people to get it within about the week after they're scheduled to get it. But the good news is that the CDC specifically has said that you can get those second doses up to 6 weeks after they would have been scheduled for the second dose without anticipating issues related to efficacy or protection. So if you are being scheduled out, you know, a week or 2 or 3 or actually up to 6, they say, not a concern there related to get protection against the vaccine. So we don't want people to extrapolate from that, you know, once we're outside of the storm, let's actually wait another month and let's do this. We want people to get it on time because we distribute vaccine planning for people to get it in that week approximately on time. But if there are delays related to storm, and you can check the CDC website if you want to see the details on this, no sooner than 4 days earlier than planned, no later than 6 weeks later than planned. So hopefully that puts some people at ease where we have had to reschedule appointments.
Got it. So I think that probably answers Stacy Baca's question from Facebook, which was update us on the weather's impact.
Yep.
And then someone asked, when do you expect to get vaccine shipments? We're still hopeful.
We're still hopeful. So again, the Pfizer is pretty much back on track here. And just for awareness, so the Pfizer vaccine, that's our ultra cold vaccine. That's all the vaccine that the city of Chicago handles. We have all the freezers and the logistics to really do that. So anything that is through city of Chicago points of dispensing or our mobile vaccination teams or kind of our partner pieces, that's Pfizer vaccine. Also, most of our hospitals get Pfizer vaccine. They tend to have that ultra cold storage. And it's really more the outpatient settings that primarily get the Moderna. So we are hopeful that the Moderna will be able to ship out today, meaning that we would expect it to be getting here tomorrow, but it could be Monday even, right? Depending, more snow today. And I think in a lot of ways, many places, especially the outpatients, are doing a lot of rescheduling of folks over the next week or two. And, you know, we can't control the weather. That's just the way it is. We will, though, absolutely catch up on this. We have plenty of capacity in terms of, you know, having additional vaccine related to this week. And I don't have any concerns about it impacting, you know, long-term efficiency. And importantly, no vaccine being wasted. Can't say that enough. No vaccine being wasted as a result of this storm.
Yeah, it seems like a logistical nightmare on a number of levels.
Yeah, yeah.
Kind of like, you know, domino effect.
Yes.
Okay, here's a question from @Jam Facebook. What is the CDC updated guidance on double masking?
Oh, okay, good. Good question.
I've seen people who are now have two masks on.
Yes, absolutely. So the CDC, a couple pieces on this. First of all, they released a study that was looking at mannequins and sort of showing that if you have more layers of covering over your mouth, you have more protection against COVID. Not a surprise. We've actually known that all along. It's part of why we recommend having multiple layers of cloth in your masks,
Right.
where you think about the kind of mask that you're choosing, making sure it has a good fit. They did not, let's be really clear about this, they did not say everybody needs to wear 2 masks.
Okay.
What they actually put out was additional guidance to make sure your mask fits snugly around your face, and to pick a mask that's got layers of some kind in it. And then some of the ways that they laid out, one example of that was double masking. But let's actually talk about that, because there's a few pieces to this. Number one, the actual specific recommendation around double masking is not to wear 2 of those disposable surgical masks together. You shouldn't do that. That doesn't help. That's not what they're designed for. You also shouldn't you don't need to be trying to wear multiple cloth masks on top of each other. The most important thing is you wear a mask. You wear a mask, you wear a mask, you wear a mask. It covers your nose, it covers your mouth, and it's got a good fit. That's the most important thing. The double masking, really the recommendation, if you decide to go that route, is to wear one of those surgical masks, one of the more paper ones, and then a cloth mask over the top of it. But if you actually look at the CDC guidance, and I would encourage you to Google it and look up the details, they actually have a number of recommendations, and I printed it out guessing that, I knew we'd had questions about this. So some recommendations that they make is, choose a mask that has a nose wire, ideally. That's the metal strip. It helps fit it around your nose, have a better fit. Think about using a mask fitter. You can do rubber bands, anything that makes the mask tighter on your face. They recommend. Check that it fits snugly over your nose, mouth, and chin. And then this adding layers of material. And they specifically say there's 2 ways to layer. Use a cloth mask that has multiple layers of fabric, or wear 1 disposable mask underneath a cloth mask. And the really idea of that is just that the cloth mask helps the seal come a little bit more. There's some details if you are using the paper 3-ply mask, how you can fold it to get a little bit of a tighter seal. We could show that maybe next week if people have questions. But you should not combine 2 disposable masks. You also should not try to add a second mask if you've got one of the KN95s, because those are already designed to fit tightly on your face. So check out the CDC website on this if you want some more details. But the main thing is I want people to mostly be wearing that mask. If it covers your nose, your mouth, it's got a good tight fit, and it's got multiple layers of cloth. We've been talking about this all along.
Yeah.
As opposed to, and we showed, if you remember, probably 6 months ago, one of my favorite visuals from all time has been that the sneezing.
That was a great
Remember
visual.
that? And how much of your droplets come out if you're wearing sort of a very thin, like a t-shirt that you can see through versus a double layer cloth mask versus a surgical mask.
Right.
So,
and to be clear,
yes.
Those masks may look like they have 1 layer, but it's just that the fabric itself is layered.
Yes,
Yeah.
exactly,
Yeah.
exactly.
Yeah.
So, so those were really the recommendations. I think continuing to have additional guidance about how to help protect others and yourself. But really the most important thing, wear that mask. And if you've got access to some of those surgical masks covered by a cloth mask, add some protection to it. But I don't want you thinking, because I don't have one of these or this, my mask isn't being helpful. Wear a mask with multiple layers and make sure it has a good fit. Lots of good tips on there about how you can do that.
Is this double masking a thing because of all we've been hearing about the variants?
Yeah, I think so. I think this is really, and I'm pleased, let me be clear, that people are wanting to be really serious about ways that they can protect themselves and others. And with the variants, there is generally, I think, even though our numbers are looking very good and they're heading the right direction, part of those numbers are people who have variants. We know that, even here in Chicago, right? The numbers have been relatively small at this point, but we absolutely have detected people here in Chicago who have particularly that variant that initially emerged from the UK. And we do a lot of sort of extra contact tracing and case investigation around those cases. We have also had some examples of spread, not widespread of that, but of spread. And that's not a surprise, because the thing with this variant is that it is more transmissible. It can be spread more easily. And so where people let their guard down. They're not wearing a mask. They're not keeping it over their nose and their mouth. They're gathering, et cetera. We want to always give COVID fewer opportunities to spread, but particularly where there are variants, even less of an opportunity. So I'm pleased by this conversation and that people are interested in, are there things that I can do to help protect myself and others even more? I just don't want this double mask conversation to sort of overweigh the fact the most important thing is everybody wears it, and that you're pairing the masking with the distancing, with the hand washing, and that vaccination is sort of coming into this as one of the mitigation strategies, but not replacing all of the things that have gotten us this far.
It's like the icing on top.
Yeah.
Okay, at Shay from Twitter, why aren't people who are under 65 with health issues getting vaccinated, but young healthy people that are working in doctor's offices are getting vaccinated? I am a cancer survivor and have to be checked every 6 months. Why do I have to wait?
Sure. So couple pieces on that. Really good question. We answer variations of this question every day. And let me just start by saying these are difficult decisions when they are made at every level. We've worked very hard here to follow the federal guidance and the state guidance, because the state has followed the federal guidance. And if you look at that guidance from the CDC, from the ACIP, the group that advises about immunization practices, Group 1A, which we are now through, was for healthcare workers specifically. And part of that is because we want our healthcare settings as safe as they can be, because you as a cancer survivor are coming into those settings for healthcare, right? Having those settings protected is important in terms of protecting our healthcare system generally, in case we see another COVID surge or whatever else may come along. But it is also recognizing that many vulnerable people come into these settings, and getting those people protected indirectly helps protect people at high risk. And so the recommendation, very clear across the whole country, to start with those healthcare workers. And so it's true that there are younger people who may not have underlying conditions who work in those healthcare settings, yet those people are able to contract COVID, to spread COVID, et cetera. And having healthcare settings be as safe as they can be is really critical. For the same reason, we very much prioritized working on home health aides here. We know that home health aides come into homes for people who may have severe underlying conditions, need a lot of hands-on care, maybe homebound themselves, are not leaving. Their biggest risk for COVID is people coming into the home and providing care. So that is following really all of the guidance. It's a best practice around the world, around the country. And just personally, having worked on outbreaks even before COVID, like Ebola, and seeing what it is like to have your healthcare system really decimated and taken to its knees by an outbreak, protecting our healthcare system really does come first. So that's why we started with that group. As we expanded to 1B, just to talk through about this, because it's we again, following those CDC, ACIP guidance, prioritizing older people. The CDC actually recommended people over 75. Here in Illinois, the recommendation was to bring that to 65, which we followed. And then the frontline essential workers that are working in the highest risk settings, plus the K through 12 education, recommending that K through 12 education, where we can make sure that that's being supported. Many states, actually, about half the states did not vaccinate K through 12 educators. We are vaccinating them here, but as part of a group of all of the people who are getting vaccinated. There's all these chains. And the point of vaccinating the people over 65 is that all comers, these are the folks at highest risk. Like, it's been very clear. You look at our data here in Chicago, across the country, the older people are, the higher their risk is for severe COVID outcomes, hospitalizations and deaths. And especially where you look at the people over 70, over 80, over 90, you look at the folks in these long-term care facilities, though that is the highest risk way. And frankly, somebody's age is a lot easier, where we're thinking about vaccinating a whole population to sort of make some lines on, than trying to have people prove various histories and underlying conditions, et cetera. But then also pairing that with pushing vaccine to the settings that have been driving our COVID outbreak. So where we've been doing first responders, where we've been doing the correctional officers, where we've been vaccinating in some of these manufacturing or grocery settings, some of the transit, the settings where we've really seen you can't have mitigation strategies in place. And we've seen very high rates of COVID infection. And then pairing that with Under Protect Chicago, pushing vaccine to the parts of our city that have been hardest hit by COVID and are the highest risk, less connection, all of that in turn helps decrease everybody's risk for COVID. So you as a cancer survivor have not yet had the opportunity to be vaccinated for COVID, but getting all of these other people vaccinated indirectly does decrease your risk for COVID exposure here in Chicago. And as more vaccine gets here and we move into that 1C phase, you will be prioritized in 1C to begin to be able to receive vaccine. So I know that it's hard where we don't have enough vaccine for everybody. Even this week, we're getting less than 7,000 first doses per day. And we've got more than 700,000 people who are eligible in phase 1B, as we've shared. So, you know, we want nothing more than to get everybody vaccinated. And we are going to be able to get everybody vaccinated here in Chicago. I'm confident over the next, few months, really heading into probably early summer. But right now, we remain sort of in that primary group. And the CDC has not changed its guidance on that. I want to be really clear. They have not changed any recommendations around bringing additional groups earlier or moving them into switching up 1B, 1C. We really continue to follow that guidance and look forward to expanding it as we have more vaccine.
Thank you for that.
It was a long answer.
That was a very comprehensive
Sorry,
answer.
maybe we could do some quicker, but
I was saying thank you because it is important to think about the ecosystems that are being protected through the way that these prioritizations have been set up. So, and thank you, Akshay, for your question. All right, here's one from Benita Sims from Facebook. What's up with the Johnson & Johnson vaccine, Doc? Benita, I tried to embody you.
That's awesome. All right, so the Johnson & Johnson vaccine, right now the FDA is reviewing all of the trial data. So just as a reminder, before a vaccine can be authorized for use here in the US, the phase 3 trial needs to have enrolled enough people, have followed all of those people for at least 2 months post-vaccination, have shown good safety, good efficacy, and then you submit all that data to the FDA, and the scientists there go over it with about 12 fine-tooth combs. They are looking at every piece of those trials to make sure that they are done appropriately, that the conclusions are correct. And then on February 26th, the advisory committee, which is the independent, non-governmental group that basically advises the FDA, looks at all of this data, makes a recommendation about whether it should be granted emergency use authorization. The FDA typically follows that recommendation. And then the CDC also takes a look through the Advisory Committee on Immunization Practices. Again, the non-governmental group of scientists that look at the data. They actually make the recommendation for how the vaccine should be used, who it should be offered to. And so these play important roles. I expect they will, based on the preliminary data, I think it is likely that we will see an emergency use authorization from the FDA shortly after February 26th, and I'm sure the CDC will be meeting quickly after that. If that all happens, we would probably expect to start getting some of that additional vaccine here in early March. But there are a lot of steps that have to happen. Most important, making sure that the safety and efficacy of this is good. And then once that data is more publicly available, we'll be able to talk in some more detail about what we saw in the trial and make some recommendations here following the CDC about that use. There have not been hundreds of millions of doses of J&J vaccine produced. I want people to know that. So we're not anticipating an enormous influx of vaccine, even if this is approved, but another vaccine would be really excellent news.
All right. And important to note that the 2 vaccines we have now went through those very same steps, right?
They did.
These are the steps that you must go through to get to the point where
That's right. And all the vaccines and the drugs that we use in the United States go through those same levels. So I know it feels a little slow to people right now, but you can't speed it up. And it's sort of the opposite of the question we were getting a month or two ago about, well, how was this done so quickly? Like, this is the speed at which these trials and their review process happens, and it's using this process that we feel, I at least feel very confident in being able to be very secure in the safety, the efficacy, and the process that we use to keep these appropriate for the U.S.
All right. D. Sanders from Facebook. If all members of group, maybe that was supposed to say a certain group, have received the second dose of vaccine, can they socialize together? Oh, if all members of a group have received the second dose of vaccine, can they socialize together without masks?
All right, not just yet. And I know this is hard for people. As more and more people are getting vaccines, first let me make one little point on that. We don't even start talking about that 95% protection until after both doses of vaccine. And even there, in the trial CDC, we talk about 2 weeks post the second dose. So that's just sort of a slight aside. But still, with the amount of COVID here and the relatively few number of people who have been vaccinated, we are still recommending that people continue to do the masking, do the distancing. As we see our numbers continue to improve, as we see vaccination numbers continue to go up, we will be making adjustments to those recommendations. These folks can gather with a whole lot less worry. Certainly at some level, people are going to make that individual level decision for themselves. But at the public health kind of level, if you're gathering with people who normally wouldn't gather, we do ask you to continue doing the things that have gotten us this far. We will be loosening some of those restrictions as time goes on here, assuming that we don't see surges from variants and other problems. So you can gather with a lot less worry, but please don't just think I'm vaccinated and therefore I can stop doing the COVID things that we do need everybody still doing.
Yeah, to keep us below that 5%. Juan Rangel from Facebook. How many variants are there, and will there need to be a second round of vaccines if the current vaccines aren't effective against all the new variants?
Yeah, really good questions. So all viruses mutate all the time. Most of the time, a quote variant or a change does not alter the way that the virus behaves in any way. There's these sort of silent mutations that they're called. When we label something a variant, it's typically because there's been a series of changes that start to impact a little bit the way that virus is behaving. And then if you have a major change, you would actually start to call it a whole new strain of virus. We have not seen a whole new strain, okay? And you talk flu or something, there's all these different strains. It's why we have to have different vaccines every year. There are a lot of different variants that have been detected. Every time a coronavirus gets its genetic fingerprint taken, that is uploaded to an international database so that the scientists can compare these changes. Where you hear us talking about the variants of concern, we're talking about ones that look like they in some way have evolved to make them more concerning in some way. So the one that emerged from the UK looks like it is more contagious, more transmissible. The one that emerged from South Africa looks like it makes the vaccines not quite as protective. The vaccines are still protective, let's be clear. It's not that it doesn't work, but maybe you go from a 95% protection back to more of a 70, 60, somewhere in that range percent protection. Certainly that's of concern, because if you continue to see that evolving, you worry about that. And then there's the one from Brazil that emerged in a setting where we had previously seen a very high amount of natural infection. And there are some questions about the way that that variant is interfacing and are people not having that natural protection. So each of these we learn about, but there are a lot of different variants and all of them are being studied and tracked. And this is where a lot of this additional investment in the molecular surveillance is so important. At this point, there has not been a need to say we need to create another vaccine. But let me tell you, all the companies are hard at work, even especially given that South African variant, which frankly emerged partly because vaccine trials were being done. And what they saw were these vaccine trials, the vaccine was much more protective in the UK, for example, or the US than it was in South Africa. And that was part of what made the scientists start saying, what's the difference here, right? This isn't something genetically that the humans have differently. This is something about the way the virus has mutated. So it's this interesting mix of epidemiology and kind of genetics. But not to get too off track.
It's fascinating.
It is fascinating, but it's fascinating. But to bring it back to the original question, it is possible that in the future we may need to get a booster vaccine. If there is a variant that emerges that turns out to not be protective against, that the current vaccines are not protective against. We're not there right now. We may never get there, but there's work being done in case we got to this point. So,
is there any, and I don't want to take us down a rabbit hole, but I do have this question.
Yes.
The two vaccines, Pfizer and Moderna, that we're using here in Chicago are mRNA vaccines, which was kind of seemed to be a newer, different way to do a vaccine. Does that make for any difference with variants and?
Yeah, so good question. So, you know, the mRNA technology had been around for a long time, but in terms of using this in this vaccine way, that was newer. And one of the good things is that the mRNA vaccines are, you could more quickly make changes to them if you needed to, because all you're doing is sort of changing the instructions for the protein that your muscle cell basically needs to make. As opposed to the more traditional vaccines, we think about needing months and months and months to grow them to, you know, the way that we have previously produced vaccines takes many, many, many months, and it's a long time to make alterations to those. It's part of why, you know, we think of these on a yearly cycle. So in all cases at this point, the main concerns that we've seen related to variants are mostly due to changes that we're seeing in that spike protein, the spike protein that gives the coronavirus its name, the crown. That spike is also sort of how the virus connects to your cell and kind of gets into your cell. It's also the thing that makes the virus very different than our human cells. I had an interesting question. Somebody asked me outside Facebook the other day about, you know, do I need to
get questions outside of Facebook?
All day, every day. Someone asked, how, you know, should I be worried that the vaccine will trigger autoimmune problems? Like, will the vaccine make my body recognize? And no, because I mean, generally speaking, no, because the way that the vaccine is designed, it teaches your body literally to recognize that spike protein. Your cells don't have this spike protein on it, right? Yeah. And so a lot of the work around vaccines, all the different kinds of vaccines, has been focused on the spike. So particularly where we see mutations in that spike, it suggests it might make it easier for the coronavirus to get into the cell. It also might impact the vaccine. So that's like where we see a variant pop up or a change pop up in some other area of the vaccine, of the virus, we don't worry as much. Mostly in this spike area is where there's been a lot of attention. And it's not just one change, it's sort of this group of changes. And it's some of the most interesting actually reading I've been doing. I don't think we'll go down this rabbit hole again further just right now, but really seeing how the virus has changed and how even in individuals who have had longer COVID infections, it's sometimes been able to change, and thinking kind of strategically about how do we make sure that we're tracking that protection. And even here in Chicago, just to bring it back home a minute, you know, we are looking really closely at any time that we see somebody get reinfected with COVID, for example, right? Like if they had COVID and it looks like they've maybe had another reinfection, we do extra investigation. We'd be looking at that genetic sequence. If we see somebody, you know, we expect a very small number of people, even who are fully vaccinated, you know, 95% protective, you will still see a small number of people potentially get COVID. In those settings, those are people we want to look at their, you know, was there a variant there? Was there a change? So there's some really interesting behind the scenes epidemiology happening testing related to looking at the variants themselves, but also looking at any anomalies or anything sort of unexpected that we see. And we've been doing this in partnership now kind of for months, not seeing anything of concern emerge, but there is a lot of behind the scenes epidemiology work where we think about how to track this and really try to stay ahead of any potential changes in the virus.
Okay. Yes, yes, we maybe we'll have a Science Saturday on this.
Yes.
Okay, back to your questions. Kevin Lavana from Facebook. ZocDoc is a great first step in aggregating vaccine availability. Is there any plan to roll other vaccine centers like Jewel Osco, Walgreens, et cetera, into one consolidated platform?
Good question. So I would like nothing more than every vaccine provider in the entire US to be attached to one system, ideally. That is not where we are as a country. I'm not going to get on my soapbox. We are a country that largely is not set up to have a very interactive healthcare system, right? Like generally our electronic health records don't talk to each other. You have probably seen this if you've gone to one doctor and gotten a test. If you go to another doctor or another health system,
They have a whole new MyChart account.
They have a whole new MyChart account. They can't see the x-ray that you got at this hospital over here. Our system is not set up to be very interoperable. And there are privacy things around that. There are, frankly, I think some proprietary and software. And it is one of the issues that we are having here is the fact that we don't have a national healthcare system. Let's just sort of say that straight out.
Oh, you just went and said it. Okay.
I just went and said it. But I mean, regardless, like it has highlighted, I think for me and for a lot of us, the need to make sure that we can have more interconnection between systems. And so something as basic as making sure that every electronic health record and every pharmacy and every place is communicating where people are getting vaccinated into a secure and central way. And then also thinking about where those are appointments, how to link up there, has been a major challenge, not just here, but across the country. And it's one of the things I'm hopeful we'll see some longer term change with. But so ZocDoc, the reason we chose it is that, first of all, it exists, right? We didn't want to build something new, and it is already the largest scheduling platform like in the country. So it is easy. It's already connected to many, many, many places, electronic health records. And we have had many more Chicago-based healthcare providers sort of sign on and sign the contracts. And as they start to have additional vaccine that's not all going to their existing patients, we will have more and more and more providers be in that network. I'm really hopeful that we will also get the pharmacies connected there. These are national chains, and so understandably, they're not wanting to solve that same conversation across the board. But our goal is to have absolutely as many sites as we can here in Chicago connected into that, and we're working really hard toward that goal.
I wonder if we're going to learn anything if we compare ourselves to maybe Canada or Britain, and we, as we look back on vaccine distribution.
I think so. Again, I will just take one example here. Israel. We have been looking at Israel very closely. They have had first of all, they got some early and extra access to Pfizer vaccine because they had a health system where they could provide really good population level data about.
They knew exactly.
Yeah, but even, Pfizer itself was very interested in looking at this at a population level, and so they were able to use their nationwide electronic health record to even get some earlier
They were attractive.
access. They were attractive, but also, let's talk about how this has worked in Israel. Everybody is in one system. There are basically 4 main provider kind of types. So, everybody's not, you don't have one company or one healthcare system that runs it, but there's 4 major ones, but they're all connected. And so literally the way that it has worked there is you have one system with all Israeli residents in that system, and you could say, everybody's got their MyChart or their phone number or whatever, and literally they call them in for appointments. So they started with their oldest people, and it's not let me try to find something. It's like, here's where your appointment is. Here's where your appointment is. It's your turn. It's your turn. It's your turn. And at a very small level, we've tried to replicate that here in Chicago by giving vaccine to our providers and then having them call their existing patients in for vaccine. We think that's really important from an equity and access and recognizing that a lot of people aren't on the internet, aren't fighting these computers. But imagine if we had a system where everybody was in here and we could just, instead of individuals sort of fighting with each other, we were able to actually say in a coordinated fashion across the whole country even, here are the people who are eligible, here are your appointments. But we don't have a health system that is set up right now to do that kind of work. And so we're trying to take these best practices that we've seen even internationally and layer them on. And I really want to thank our healthcare providers here who have been doing a really good job. We've got more than 500 enrolled, ready to get vaccine. As we get more vaccine, they've been calling in their oldest, highest risk patients. As we move ahead here, we're able to get through more of this group. We will then have them calling in their highest risk people with underlying conditions or disabilities, right? This idea of sort of going with not kind of having all of this be Hunger Games, right? And who can get it, but recognizing that where people have existing relationships with a provider, with a pharmacy, that is a good way to actually get people vaccinated. Unfortunately, we've not been able to really do that at the national level here. And I think one of the reasons we're seeing some success in terms of efficiency and equity data here in Chicago is because we've tried to replicate some of those best practices. But I'm really hopeful that one of the things that will come out of COVID long term is much more of a look at the technology that underlies our health systems, the way that our health systems talk to each other, and that we make sure that while keeping all of the privacy things in place, those lack of connections don't hurt us in the way people get regular medical care, much less some of this vaccine work.
Okay. This might be a great question to follow what you just said. This is from Laura Catherine from Facebook. Why can't my doctor release vaccine she has on site to other patients? She has vaccinated all of her 1A and 1B clients and can't move on to the next group.
We need your doctor then signed up for ZocDoc. And this is what we have been encouraging every single provider to do. I'm actually really surprised to hear that, if that is a provider here in Chicago, because that is not what we are hearing from our providers. But the whole point of signing up for ZocDoc is that, first of all, we only provide, let me, because this is a really good question. Let me kind of take a step back. Every single week, the city of Chicago allocates vaccine out. Let's just kind of be clear about that. So whether vaccine is going to a hospital, to a pharmacy, to a doctor's office, to an employer, to our mobile vaccination clinics, all of that is being coordinated on a weekly basis based on the weekly allocation we are getting from the federal government. And every single week, any provider that wants vaccine in Chicago lets us know on a weekly basis how many doses, would they like? How much sort of can they handle? And we're working on building, now that we're getting some more visibility from the federal government, we used to get just a few days advance notice. Now we're starting to get a week or two or even 3 out. We can then give that to providers that will help. But providers have to show that they are doing all of the appropriate reporting and that they've used 85% of their vaccine. And if they have used 85% of their vaccine and they still have eligible people to vaccinate, we send more. If they don't have eligible people to vaccinate, we don't send more. But we also say sign up for ZocDoc, because then that point is that if you've really gotten through everybody who's eligible, we would like you then opening up to people to serve the general population, to people maybe whose doctor has not gotten vaccine or who are not connected. And really the goal here, we're asking providers to make about 10% of their appointments available sort of in this way. But if there was a situation, first of all, Chicago Department of Public Health does not keep sending vaccine to providers if they've gotten through that whole group. But also, this is then the sort of provider that we would want to open up. And as we get through these groups, and maybe this is a very small practice, maybe your provider did get through everybody, great. Once we're able to sort of get more of the population, right, like that means we don't send to that provider. We send to the providers who still have like, let me be honest, hundreds of thousands of people over 65 who still need vaccine, we then will open up so that your provider will be able to say, just like we did in the 1A into 1B transition, we'll say, go ahead and start with your existing patients who are at the highest, have those highest risks of underlying conditions. So we will absolutely be doing that. I expect we will hopefully be doing it at some point next month, once we've gotten some more vaccine and gotten through some more of the group. But this micro level is like exactly the conversation that we have sort of at the city level and even at the national and state level, where you want to make sure you're directing vaccine in a way that you are getting through the populations that are eligible before kind of moving ahead in different ways.
Yeah, and there is a tab on the website for providers.
Yes.
So if this provider, your provider, Laura Catherine, seems like that person's already set up.
Yeah, sounds like they're getting vaccine. They need to sign up for ZocDoc. But also they wouldn't be requesting more vaccine. We would start to provide more when we were getting to a point where we were moving into 1C. And every single week, we look in detail at how much vaccine people are using. We look at to make sure that all the reporting is happening.
Yeah.
And that's part of why we've been able to get to a point where, setting aside long-term care, 100% of our vaccine is in arms, right? Within the week. Yeah, it's tricky. All of this has been a major challenge, but I really thank the providers, and I think the way that we're doing this is yielding some real benefits here, and it's setting us up really well for when there's a lot more vaccine, because we want everybody to just be able to get vaccine through their regular doctor, through their pharmacy, just like you would get a flu shot. We're going to be there in a few months, and the good news is we've already built that infrastructure, because we don't have enough vaccine to send vaccine to every provider every week, like not at all. And we make some of those equity decisions related to where are we seeing lower levels of vaccine uptake, where we prioritize that. But once there's enough vaccine, we'll be able to send it to everybody.
All right, that was our last question with the time that we have.
All right.
Do you have any good news for us, Doctor?
Yes,
today?
I feel like that was
aside from the positivity level that we're at,
yes, and the fact that 1 in 4 Chicago residents over 65. We know that means 3 in 4 haven't. We're getting to you, I promise. Yes. So one good piece of news, actually related to the larger healthcare conversation, is that open enrollment is now back.
Yes.
So from now to May 15. The Biden-Harris administration has opened a special health insurance enrollment period to ensure that every American has the opportunity to get covered. So again, in our system that does not just assume that everybody should be covered for health insurance, it is important that people have the opportunity to get covered. So please go to healthcare.gov and sign up today. If you're lower, there's lots and lots of opportunities for people to get covered, even with no payment, if you meet particular income level requirements, or there are low-cost options. But we really want to make sure everybody is eligible, and the new administration has reopened that enrollment period. So if you are not covered for health insurance right now, please do me a favor, healthcare.gov, check it out, let us know if you have questions. Getting everybody in Chicago covered, or covered from an insurance standpoint, is critical as we think about having, a healthy Chicago here. And then just maybe one other thing, a reminder, we're still seeing single-digit temperatures. If you don't have heat, if you need shelter, call 311. Lots of folks on hand to make sure that that's being addressed. We want people to be safe while it's cold.
And check on your loved ones and
Yes.
make sure that they have heat and they have shelter.
Yes.
And call 311 for them if they need it. Okay. All right, Doctor. This was like
This is a very. I'm much more conversational when I'm with you, which is fun.
I'm
so.
always happy to be in this seat. I
Yes.
think we went through a lot of questions today, all along the lines of keeping Chicago protected and keeping up all the things that we know work. While we move forward with getting as many people here vaccinated as we can, given how much vaccine we have coming in the door.
Yeah, thank you. The news is really good on vaccines. Safety, efficacy, the way it's rolling out. As more gets here, it's going to be a bigger and bigger part as we protect Chicago. But all systems go. Please, some patience. You're going to get a vaccine in March. This is our plan, especially if you're in that over 65 frontline essential worker. We're working hard on that, and we'll be expanding out more as vaccine comes.
All right.
That's it. See you next week.